Hi everybody. This video is about our own personal biases and something that we've seen in the healthcare setting, as well as what we've seen from other providers in the healthcare setting regarding bias. So the population that I chose to talk about is the female veteran population, mostly just because I have my own personal experience with this regarding bias, and I have a lot of good friends that I've also talked to about this. So I thought it would be a good topic for me to kind of dive into. The first question asks, what is one bias you can identify that you hold about this group? And I thought this was interesting. So I often find myself assuming that female veterans are separated from the military by choice, and rather than from something medical or otherwise where they were separated from the military, other than by personal choice. And it's interesting because I'm a female veteran that separated for medical reasons. So I just think it's interesting that I hold a bias for this when I am in the othered group, I guess you could say. The next question, what biases have you witnessed in the healthcare settings in the community about this group of people? So my own personal experience, I've been told that my medical concerns are just a byproduct of stress, and that the pain is just in my head. I'm imagining it. It's frustrating, and it took me years to find a physician who would honestly listen to me and take me seriously, to order appropriate tests to find the source of pain that I was having. It ended up being like a small piece of shrapnel that was causing my pain, which was easily removed in an outpatient setting. But the fact that it took me literally years of arguing with other physicians and begging them to take me seriously was a very frustrating part of my life. And the bias in that situation is that women exaggerate their pain, or that they have a low pain tolerance and they don't know what they're talking about in regards to pain. So some other things that I've witnessed include cutting a female veteran off when she's speaking because your word is bigger than hers, and it's a very hierarchical system in the VA. So if the physician is talking, especially to a female, the female is expected to stop talking. And then also telling her that her symptoms are related to PMS or her period or hormones. And then not taking pain seriously is another one. And then another big one is disregarding other symptoms in lieu of anxiety or stress or depression. So the bias in this situation is that females are just anxious and they're seeking attention, and ultimately that invalidates their experience. So something that I found interesting, I took it from an actual Committee on Veterans Affairs from 2009. It was a court hearing about specific needs for female veterans, and I found that in the article it states female veterans are at a greater disadvantage because their military assignments and records are less likely to reflect their actual service, their exposure to combat, or other traumatic events. And then women who have suffered harm of military sexual trauma, they often don't report these crimes because they don't feel safe to do so, and therefore they have no documentation that can be used as evidence, and that often results in a denial of benefits if they're seeking a military sexual trauma case. And then also, even if they do report these incidents, the perpetrator conviction rate is only 5%. So there really seems to be no upside of reporting other than predicting your future and that you're wanting to seek veteran affairs medical assistance. So, another interesting part is that 78% of female service members 78% of service members report some form of sexual harassment during their time in the military. That's a staggering number and a huge discrepancy between the care they're receiving and the care that they deserve. And also when they do go to the physician to say, hey, I'm experiencing some PTSD from my military sexual trauma, and then they chalk it up to anxiety, is a little disheartening, and it all falls down to bias. So let's see. Lastly on that topic, women veterans are less likely to be granted service-connected treatment for their post-traumatic stress disorders, even though women are more likely to report symptoms and to seek treatment for this. They're less likely to get that diagnosis. And that's from a Huang et al. 2019 that I found that article. So the next question, how do these biases affect othering behavior of this population? I found out of the Kroskeri 2013 article that there's a variety of cognitive and affective biases that compromise our decision-making process. So cognitive meaning the way that we think, our thought processes that lead to our behavioral outcomes. And then affective biases, meaning the ways that our feelings influence our judgment. So how we feel about someone or their general population group that influences how we treat them and our judgment about what they're going through. And there's two major sources of bias. There's innate, which is kind of our hardwired, developed through our evolutionary past, and then our acquired bias, which is something that we acquire in our lives based on our development, our experiences in our lives. And then there's also contextual factors, things that happen in our everyday lives. So fatigue is a big one, sleep deprivation, cognitive overload, and this can create a high-risk situation that disposes us to particular bias in our work. I also wanted to note that this article said that bias is inherent in human judgment, and physicians are also subject, because they're human, to making these biases and then producing an outcome maybe they're not intending but is ultimately happening. Considering other required readings, do people in this group get equal care to people who are not in this group? So according to the Madden et al. 2020 article, low-income patients with co-occurring behavioral and physical health conditions struggle to maintain high-quality health care. And I think this specifically encompasses the female veteran population that I was talking about earlier, because they're usually low income and they're often diagnosed with a behavioral and a physical health condition. So this kind of labels them as a complex patient. And in this article it said complex patients are misaligned with the expectations in most medical settings, and it asks these patients to pay more money or to travel to appointments, pay for higher cost prescriptions when they just simply don't have the means to do so. So complex patients often encounter barriers to engage with their health behaviors and healthcare providers, and it ultimately results in poor outcomes. The next question, what are the effects on the individual in this group, to the group as a whole, or the healthcare provider? So for the individual, they might face unnecessary stressors when going to the healthcare facility, which may actually prevent them from going. And other populations simply just don't have to face this stress. This can increase stress, anxiety, and it also will build distrust within the healthcare system. As a group, it affects female veterans nationwide because they're just simply not receiving the care or the quality of care that they're deserving. So their health is at risk because they're not receiving the care they need. And kind of spinning that around, effect on a healthcare provider, if they do care about the female veteran, which I hope most of them do, but if they actually want to change these implicit or other biases that they might have, they might be overwhelmed with patients who are seeking their individualized care, because they are trying to take on patients from other providers. Stop! Sorry, my cats. They're taking on other patients from providers who maybe aren't doing as well as they should be, and between the veteran community, they're speaking, oh hey, I found this provider that's great, and so they might actually feel overwhelmed with patient numbers in that sort of way. And then they may also face guilt of knowing that they can't take on more patients than they already have, because they want to give them the care they deserve, but they don't have the means to do so. Also, they can counsel other physicians, and that can be uncomfortable and stressful for them as well. So the last question, if you could change the healthcare system to meet the needs of the population, what would you do to design, or what would you design into the system? How would you train healthcare providers with their biases to ensure that this other group receives quality healthcare? I think firstly and always, education is important. Educate healthcare teams to not only address their bias, or I should say to train them to first recognize that they are having a bias, or educate them on what the most common biases are, and then additionally train them how to negate those biases, how to work around them, to identify, address, admit it to yourself honestly, and then make a change. Lastly, I would also encourage improvement of engagement with female veterans. According to the Madden et al. 2020 article, more engagement with a biased population has been shown to cause team member burnout as a result of increased effort. But professional support offered by the team structure was shown to reduce this effect. So improving team structure of healthcare facilities and team management can go a long way in receiving, or in the care that's received by the female veteran population. Thanks.